payers are caught in this limbo area of thinking population health, but being responsible at the patient level, and which is your member, your client.
Yeah.
So how do you balance the two when you start to think about value and cost?
Well, when I was on the payer side, and Mike knows this well, we knew all of the rules regarding our various patient populations. Commercial, who was fully insured, commercial, who was self-insured by employer, Medicare and Medicaid, and the rules of the government. So we knew what was going on in those worlds, and how we could try to pull levers to get more value for the care that we were doing, both in the population health basis, for example, cardiovascular disease, versus the high cost, low incidence diseases like cancer. In the commercial population, about 0.6 per thousand, Medicare maybe about 4 per thousand. And that leads to different strategies. For population-based care, you can really implement value-based insurance design, because the treatments are not expensive, and you can remove some of those barriers without hurting anyone's bottom line, and you can impact a lot of people who get it. It's not a difficult equation to say, I've had a heart attack, now my ACE inhibitor and my beta blocker are free. Okay, more people are going to take ACE inhibitors and beta blockers. So I totally get that. On the high cost, low incidence diseases, where we struggle because the 5% of the population typically incurs 50% of the cost, the solutions have to be more personalized, but at the same time, as Mike pointed out earlier, the decision maker is often not the patient, and as Alan said, it's often the system. The reason being the disease is so complicated that you often need to have the decision making worked through or primarily made by the provider or the provider group. And so that leads you into the types of programs like oncology medical homes, where you say, the patient's really not going to be able to pick one of those 16 NCCN regimens for HER2 negative, tumor node positive breast cancer. But if I have a provider practice that signed a contract that says they're going to use a narrowed portion of evidence-based medicine, then I've kind of delegated that value to the practice, and all I have to do is create an insurance design that creates a tiered network so that more patients will go there. And then I've tried to solve that by doing sort of a network model and delegating responsibility and maybe some upwards and downwards risk to the provider group. So that's how I've looked at it on the payer side. On the pharma side, it gets a little more complicated, because one thing Ted didn't say, but my mother-in-law says, nobody pays retail. So what's being touted out there, and I want James's opinion because he's more of a veteran than I am, as cost is not actually the real cost. And when I think about the hierarchy of what I would want to eliminate to create more efficiency in the system, I'm not so sure I'd want to take a swing at the innovators first, because there's so much grit in the machine that there's a lot of other things we can do to lower cost. We didn't talk about that political third rail that's a little less electric but still electric, which is what are we doing with medical futility and care that's given at the end of life. We haven't really talked about why there's such low enrollments in clinical trials, and we haven't talked about why people are hogging their data and locking it up in safes and not allowing innovation to move quicker. So I would rather take swings at those elements of the system that need to be fixed than something that involves a price that's not really a price, that, as Ted alluded to, in 340B, that price is not actually the price.